steps, promoting patient safety, improving health.
So we wanted to set this up as if it was a live simulation to what you guys would be accustomed to in the actual OR. So I'm a visual learner, so every simulation that we do on the adult side, I try to make it as visual as possible so that you can actually see what everybody's role is in this instance. This like plastic shield is very reflective, so I'm sorry. I feel like Ace Ventura where he's peeking out of the car. So this is just a brief presentation room, just to go over really quickly what ECMO actually is. It stands for extracorporeal membrane oxygenation, and it's also known as ECLS. So there's two different abbreviations for it. We're providing respiratory support and cardiac support in the event that there's a respiratory or cardiac situation where the patient needs these extra measures. So anything conventional is failing, we can put them on ECMO support to give them that extra boost that they need to recover. At WVU, we use three different systems. We have the Thoratec Centromag, you can see it on the far left. We have the McKay Cardio Help, which is in the middle. And we just recently acquired the Fresenius Novolung. There's a broad spectrum of different ECLS systems that we can use. However, these are the three main ones that we use here. Obviously, ECMO is comprised of different circuit components, just like your nursing, just like your surgical fields. There's different types of tools that you need to make everything run appropriately. So we have cannulas, we have tubing. We use centrifugal pump heads. That's the pump head you can see at the top right of the corner. The tubing pack is on the left-hand side. That's what we use to actually build the system. At the bottom, you'll see our heat exchanger, so we can actually cool or heat the patient depending upon their situation and what actually has occurred. There's different types of saturation connectors. We have bubble detectors, all different kinds of safety features that are involved in our circuitry itself, which you'll see it's over there on the far left of the stage. You'll actually see it be put on a patient. But we take all precautions that we can necessary to protect our patients when utilizing this therapy. Obviously, there's a multitude of cannulas that we use here. Most of the time, you'll see the 25 French multi-stage for a venous access point, and then we have a 20 French Funflex. Cannulas are different in the aspect of where the holes are and how big they are. So obviously, bigger patients, we're going to use bigger cannulas, right? And then the hole situation is for drainage from the patient. So we want to pull as much blood as we can from that patient so that we can return it very nicely, heavily oxygenated to give them the recovery time that they need, whether it is a circulatory arrest or a respiratory arrest in that respect. There's also kits that we use, and you'll see them whenever we do the cannulation. There's a PIC A kit, so PIC A, so that would be for your arterial cannula. And then you have PIC V for your venous cannula. There's also an Avalon insertion kit that's in your ECMO bin. So 5 North has its own separate ECMO bin that has these supplies in there. There's an Avalon insertion kit, which you'll see us use on stage today. That's what we're using primarily now for inserting these cannulas into these patients. And the surgical team and the surgeons are very prominent in asking for it. So you'll get to see that as well. Dr. Hanga, Dr. Sappington, who are on stage, and they do a lot of the cannulations, Dr. Cook, Dr. Way, whoever comes that's on call for that ECMO patient will ask for these items. I just want you guys to know that we are prepared in the fact that they are in your bin and ready to go for you. But if you have any questions during that time, don't be afraid to ask anyone. They'll help you out with anything that you need, especially surgical techs. When you're handed up cannulas, do not be afraid to ask which cannula goes where. Obviously, you can see different holes in the cannulas as far as that spectrum goes, but you might have this lovely presentation and not see an ECMO for a year. So do not be afraid to speak up and ask questions at all times. We have different oxygenators that we use to oxygenate the blood. We have the AMG, the Nautilus is the boxier one on the left, and then we have the Quadrox, which is the white at the bottom, and then we have the McKay Cardio Help. All of these are what actually supply the oxygen back to the patient. So when we're getting that deoxygenated blood from the venous cannula, we're pulling it down into our system, and we're returning it heavily oxygenated through one of these systems here. And then obviously we have the blood pump, which is actually pulling the blood from the patient and then pushing it through to that oxygenator itself. All of our circuit management, our building, priming, monitoring, safety measures, management, even education, we all follow the ELSO guidelines. So ELSO is pretty much the big crux of how we build all of our ECMO programs across the nation. And WU really takes pride in making sure that we follow all of those guidelines. We're actually an excellent center of excellence right now, and we're trying to get up to that next stage of gold level center. So we're working really hard to keep building our program and keep going through the ELSO guidelines to make sure that we hit that goal. There's obviously two different types of ECMO. We have veno-arterial and veno-venous. So your VA ECMO or veno-arterial is when your oxygenator is working in parallel with your native lungs, and it's providing that full hemodynamic support that that patient needs because their heart needs rest as well as their lungs. Our oxygenation, so everything that's going through that box or that oxygenator that's in our circuit itself, is influenced by how fast we're flowing. How fast is that pump moving that blood through the system itself? What's the patient's hemoglobin? Do we have great oxygen carrying capacity to provide that patient what they need? And how's our pulmonary blood flow itself looking? For VV ECMO, our oxygenator is working in series. Let me see if I can slide this over for you. Is working in series with the native lungs itself. So it's providing respiratory support only. So you need that cardiac function to really push that blood flow through the patient's system. And that oxygenation, again, blood moving through that circuit, through that oxygenator, is influenced again by your pump flow. How fast are we pulling from the patient to return? Again, your oxygenation, your oxygen carrying capacity of the patient themselves, and our native lung function. So what are we looking at as far as our lungs are? Slide back over. So sometimes we will see emergent cannulations where you have ECLS that's in need, or you have a cardiac arrest, or any type of those resuscitative measures have failed, as we talked about earlier, and ECMO support does need to be initiated. When this happens, and it's typically what you guys will see, this is when you're going to call the surgeon and make sure that that patient is even a viable ECMO candidate prior to just getting the whole team there and having them all run in abruptly. So in the operating room, you're going to run the code as you would any other. You're going to be giving medications. You're going to be giving blood, volume, anything that you can get that patient back and do a good thing. You might even be giving some CPR. And during this, while you're cannulating and you're giving chest compressions, Dr. Hayenga or Dr. Sappington might say, stop CPR for a hot minute so that they can get that cannula in there. So let's just run through a quick little scenario before we start the live one on stage. So you're on doing your surgery and the surgeon states, can we call for ECMO? Patient's desatting, becoming hypotensive, anything along those measures that would require him to ask that question. Again, you're going to page the on-call ECMO surgeon first. So your circulating nurse, page, call them, say, we need to page the ECMO on-call surgeon. Dr. Hayenga is going to call you. He's going to talk to you about that patient. Say, why do we need ECMO? What are the comorbidities? What's going on? They might be a candidate. They might not be a candidate. It's all based off that surgeon's patient selection criteria and what they think this patient actually does or does not need. If the surgeon states the patient is an ECMO candidate, as a circulating nurse, you're going to page the entire ECMO team. And to do that, you're going to dial that 74012 number. And I believe that Ari is going to put sheets in the OR so that you guys are aware of these numbers to call and how to follow this nice algorithm so that it does flow nice and smoothly for you when it does happen. You're going to tell ECMO for a patient and what OR it is. And this is then going to send out a mass page to the entire ECMO team. So you're going to have perfusion, the specialist, the surgeon's going to get the page. Everyone's going to come to that room in that area in need for the ECMO, bringing the supplies. So again, that ECMO team's page, everyone's going to come and we're going to grab supplies from the equipment room that's located on the 3rd floor. And you guys have your bin as well. The supplies that we're grabbing is that prime circuit. So you're going to see us drudging through, trying to kick everybody out of the way to get into that OR. It's going to be absolute mayhem. And then we also have a cart called our rainbow cart, and it has just our necessary ECMO supplies on that as well. But we're big precursors of teamwork. So when we come into the room, if you need help, if nursing needs help, if the surgical tech needs help, if you need us to hand up anything to the field, we all work collaboratively as a team. And communication, as we all know, that's why we're in this, is a big deal in our field, right? If the surgical tech doesn't communicate to the surgeon, if the surgeon doesn't communicate well to the surgical tech, everything falls. So we want to make sure that we always are assisting everybody and helping out as much as we can. So just to run through this one more time, because I know you might never see this again. If you are the circulating nurse, page the on-call surgeon first, chat with them, see what's going on. They are very kind people. They will not attack you, I promise you. They might even chuckle. Just see if that patient is actually a good candidate prior to paging the entire ECMO team. You don't want to have this big, huge conglomerate of people where you have a room like this, where there's 1,000 people running in and then you don't even need our services whatsoever. Surgical tech. Obviously, you're going to assist the surgeon cannulating. You're going to hand up the necessary supplies and cannulas. Tamisa's here. She's from the 2 South OR, and she's great. She's going to show you everything that you need to do in that respect. Your draping is going to change with how that you even get access points to the cannula sites needed. So these are all things to pay attention to whenever she's working. You might need the sternal saw, so we're going to go through that. It's a drop-in battery, and the batteries stay in the CVICU. We have them with us, so we can bring them with us whenever we grab our equipment from the CVICU. If not, some carts already have the surgical saw on them. Maybe, I'm not sure how yours are, so you can always prep and get that ready as well. For different types of VV cannula locations, we always go for the right IJ and then the femoral vein, which is what you're going to see today. You can use a dual lumen catheter also for the right IJ, so that you would only have one cannula. That's it, versus the two that you're going to be seeing. So there's different types of areas, and again, those different types of cannulas. Don't be afraid to ask questions though with whatever we end up bringing to the table for this patient in need. Every patient might require something different. That's why we're here to help. And for VA cannulations, the same exact thing. You might have dual neck cannulation with the right IJ and the RCCA. You might have a dual fem, so you might have to change your drapes for the dual fem cannulation. Different things, again, don't be afraid to ask. Dr. Hayenga, what type of cannulation would you like us to do? Let me change my drapes real quick so that we can make sure that we're prepped and access ready for you. Just follow the lines. You can even have the circulating nurse ask, what kind of cannulation would you like to do, so that we can prep and get that patient ready, so that you're even ready to go prior to Dr. Hayenga walking into the room. After post initiation, we want to make sure that those cannulas are in a good spot and they're in a good place for the patient, especially if we're having any type of flow issues. You might hear the specialist or the perfusionist say some comments like, we're having some chattering, can we give some volume, things along those lines. We might have to do another chest x-ray to even check and make sure that our cannulas are not too deep or out too far, so that we can hit adequate pressures. And remember, those flow are very important for the impedance of the patient, right? So we want to make sure that we're providing as much oxygenation and stability that we can for that patient need. So you're going to look at chest x-rays. The surgeon's going to approve them before we even leave the room and make sure that everything's stable and okay. So while it looks like we might be just sitting and hanging out waiting for you guys to call us, our brains are constantly going with, what do we do if this happens? What do I do if that happens? And I'm sure because you all work in the OR, you function the same exact height that we do. So, you know, you're always thinking, you're always on edge, always on your tippy toes, but we just want to praise you all that. Everything you do is absolutely phenomenal, but please don't be afraid to ask us questions. That's why we're here. We're all here to learn, and we know that you guys can even teach us something as well as us teaching you. Is there any questions thus far before we get started? So quiet. Oh, yay.
So when you actually take a patient off of ECMO, how much blood loss is there that's through the machinery?
Oh, so the priming circuit itself is only about 500 cc's of blood. So you actually don't lose any because we prime it with P light, plasma light. So we're actually just replacing what we can. So you might have to give blood just because you give them a diluted hematocrit to start. But these patients typically are so big that you're not really doing any damage. But I mean, you can always do a lab draw right after. Typically we do that anyways because we have to start heparinization and anticoagulation post, so that we ensure we don't clot off the cannulas or the circuit itself. So we'll usually do a full lab set, make sure that everything's good and stable as far as that's concerned, including your gases. You want to make sure you do any type of ABG or VBG that we can get on the patient, so that we know that we're giving them the right oxygenation that they need and we're not overshooting or undershooting by any means. Any other questions? That was a good question. Okay. So we're going to set the scene. You want to set the scene with the patient? That won't help you. My bag won't help you. After we're done, I'll introduce you guys to everybody.
So this is a 24-year-old young man who was in an NBA with blood all chest trauma and a positive FAST in the ED. Sent emergently to the OR for an exploratory operation, secondary to the positive FAST. Initially, when you get to the OR, his oxygenation, his sats are in the mid-90s. Hemodynamics, his blood pressure systolically is in the 80s. He's tachycardic in the 140s from that standpoint. And over the course of time, what is noticed is that his O2, his saturations start to fall. A bit more tachycardic. Blood pressure still with systolics in the 80s to 90s.
Sound good? All right, we're gonna have our surgeons drape and get ready. So these would be your typical OR surgeon. So this is who you're working with in the room. We haven't paged ECMO yet. We haven't done any of that yet. It's way wrong. Well, you already put your gloves on. So we're just pretending. This is very sterile, everybody. You can judge. This is Mr. Chris Lindsay and Miss Lacey. They're from the CDICU. They're helping me. So apologies beyond. We're thankful for all help, though, right? It's still on first, y'all. You'll have to tie it first.
Well, guess what?
You gotta have some chuckles, right? That's a simulation. We got some left.
Get the microphone ready.
There you go.
I'm well enough. Oh, okay. I know we should offer that juice that.
On-call ECMO surgeon.
Go ahead and call on-call ECMO surgeon. Yes, I will.
Good morning.
Good morning. I'm calling from OR 3215 North. Our surgeons went ahead and had a surgeon. We have a 24-year-old currently open on the table. He is post-MVA. He had a positive pass in the ED, came to the OR for exploratory laparotomy. Pressures right now are hanging out 80s over 40s. He has came into the OR today with an O2 stats in the 90s, continuously dropped during the case. He's now hanging out in the high 70s to low 80s. We're unable to get him back up to appropriate AV saturation.
Trey, I'm in the middle of a Zoom in Oki Patterson Auditorium. How old is this patient?
He is 24 years old, Dr. Ariella.
So my prerogative at this point is to identify whether this patient is an ECMO candidate. The difficulty here is that ECMO is such high resource. Each of these hospitalizations costs up to $500,000 to $700,000. So I have to make sure that we don't activate the team, and this is a non-viable situation. And that may sound nihilistic and cynical, but the problem is that the order of events is important, because if we get called to put a 98-year-old who is having a giant hiatal hernia repaired on ECMO, that patient is likely not going to survive. Statistically, patients over 67 don't do well. In the context of a pandemic, this has become even worse, because patients even younger have been dying on ECMO. This COVID-19 has been a serious problem. So that gives me maybe 90 seconds to identify whether that is a viable candidate, and something that the West Virginia as a state needs to respond to in terms of the resources, because there's only a finite amount of resources available for healthcare. And so if we put everyone on ECMO, and we can, to great profit, we could bankrupt the system. So this has to be a call that discerns whether or not we can save this patient. Because if we can't, then we have to be the bearer of bad news to say that that's not a candidate. And you've seen it all in the ORs in the last 3 years, where some patients are candidates and some aren't. So I turn to Troy and I say, how old is the patient, Trey?
24 years old.
And what were the comorbidities? The heart functioning, are you on presses? Are you on inotropes?
We're on Levophed at 0.04, giving volume to get the pressure back up. No significant past medical history with this young man.
When you are called from the OR, there is an obligation to go. This is not something that you can decline on the phone. Out of respect to the patient and the OR team, you have to show your face and evaluate that face to face. So at that point, my task is to drop everything that I'm doing and get to the OR as fast as I can. The problem with resources is that this call could be at 2 in the morning or 2 in the afternoon. So we have to decide as a program, as a university, do we have the resources to do that? And right now we don't have the resources to respond within 10 minutes, 24 hours a day. We can respond probably within 20, 25 minutes, but you've all been there when we're doing chest compressions and we're waiting for a response. And there's only so long you can do chest compressions. And 25 minutes is probably that limit. So what I can say, in all honesty, is that our response in the immediate moment is probably restricted to about 18 hours of the day. And there are 6 hours of the day when we're exposed, or 6 hours of the day where it may take 30 minutes before we can activate that. But that 74012 number is like a guided missile. When you hit that button, you get a certain amount of resources. One, you get a potential helicopter on the roof within 25 minutes. That's one. That's the biggest thing you can do with that call. Because at that point, you put the helicopter pilots on standby. 2, you get the cardiac team activated as well as the OR. And then, as you know, that's a significant amount of resources. 3, and probably least important, you get the surgeon as well. But the important thing about this call is that they will show up in the OR. If you call them before the surgeon, they will show up and they'll be ready to go. And you'll make the surgeon look really bad. 1, they'll show up late after the team is already there. And 2, they may then deem the patient non-viable and not a candidate, which means then that those resources have been lost and have been wasted. And people will be driving from home from a perfusion standpoint and the OR standpoint. And so that call has to be done in conjunction with the on-call surgery team, because that will determine whether that patient will go on ECMO. So Trey, I will be there immediately, but I'm still in the Patterson Auditorium.
Yes, sir.
So I have to figure out, is there anyone closer? You know what? Dr. Sappington is available in the CBICU. I'm going to call her and she will be there before me. Dr. Sappington,
Yes.
there is a situation in OR9. Would you please go? They need an ECMO evaluation.
Absolutely, sir. On my way.
Thank you. In the interim, I have to figure out what resources we have. Do we have a bed? Do we have a pump? Do we have access to anything else that we would need in case this patient needs to have the chest open? Do we need to put them on bypass? Is the perfusionist there? I have to be preparing that while she goes to assess the patient in anticipation that this, in the context of a 24-year-old, there's very few reasons not to go on. But this is going to end up on it. So I will now, behind the scenes, try and figure out from Jamie as my representative, who's on call for perfusion, Jamie.
Lauren.
Okay, ask Lauren to be on standby because we have a situation in OR9 that might require ECMO. Then I'll wait to hear from Dr. Sappington. And in the meantime, I'll make my way to the OR.
Sure. Man. Okay. Anything in the meantime? We talk to Dr. Hanger, and we'll go from there. Dr. Hanger?
Dr. Sappington,
With a 24-year-old young man, NBA, initial CT scan of his chest shows bilateral rib fractures, small pneumothorax. His chest is replaced, no hemothorax. He had a positive FAST in the OR, in the ED, so he went to the OR for exploratory laparoscopy. No significant past medical history on this young man, previous healthy and doing well. Echo by anesthesiologist showed good biventricular function from that standpoint. And neurologically, he had a negative CT on his head, and he was awake and neurologically appropriate before sedation.
thank you, Dr. Sappington. Is there any reason why we should not go on ECMO?
There is no reason why we should not go on ECMO, and based on his echo, based on his other studies, I think we can get away with DV ECMO.
Thank you so much for that evaluation. Can we activate ECMO?
We are going to go on. Can you activate the ECMO
I
team,
will
please?
activate the ECMO team. I will call 74102.
No, 74012.
74012, excuse me.
I don't know what 7120. So that,
Somebody, 74012, and talk to Christy. She is on charge for ECMO. Hi, Christy. We're going to activate the ECMO team in OR9 on 5 North. Dr. Sappington's in here. Dr. Hango's on his way.
Okay, guys, we're going to go on. I'm going to need to press out the right IJ and right left.
usually when you call to ECMO, you arrive and there are a lot of people in the room. And that's just the nature of it, because there is a certain sense of anticipation. It's a patient that's dying. But the best thing that can happen while this choreography occurs is crowd control and assignment of duty. So very often, this is 5 minutes away from chest compression. So aligning a set of providers who will give CPR is great. That's important. The second thing that is very useful is to get an ultrasound machine. An ultrasound probe will allow access to the vein. That's useful. Third thing is wearing your badge in a place where your name can be seen. That's important because in crowds, the psychology of crowds is that when everyone is in a room, no one takes responsibility for what they think the thing to do is. So when someone shouts into a room, start CPR, it's less effective than saying, Shannon, start CPR. And the names are powerful. The pump comes in, the ultrasound is requested. The OR configuration is changed, like, you need access to the groin, the neck, and the chest. Those are the 3 points of access, because if you can't get to the groin, you open the groin. If you're ready to cut that onto the terminal vessel. If you can't get into the neck, then you're probably going to go to the chest. And so those are the priorities in terms of the prepping and the breaking. The pump will arrive by perfusion a day around 3 days. And after that, it is a coordination with the OR techs in terms of handling the tubing onto the sterile field, keeping it sterile, handing the cannulas to the surgical tech at surgery team so that you have access to the veins and the cannulas ready to go at the same time. Right now, Dr. Sappington is using the ultrasound probe to identify the right internal jugular vein, to which then, in similar fashion, is placing a port or placing a central line. She'll place a guide wire into the right jugular vein. When waiting for the OR perfusion team to arrive, it's useful to bring a cordis kit, because the cordis kit allows a 7 French or 8 French catheter that can then be rewired into a cannula configuration. The guide wire goes into the right filling segment and down to the heart. It's a much longer guide wire than normal, typically causes some tachyarrhythmias on the it's very comfortable to call out when it happens, so then the guide wire can pull back. Once that access is achieved, the sarcophagus moves to the right femoral vein and PSGS for the PIC V kit, which is a 260 millimeter guide wire that allows access to the groin, which will then be dilated up to allow for 25 French or 27 French femoral venous cannula to go in place. The medications from a circulating nurse perspective, the medications that are useful here are calcium, albumin, antidepressant, vasopressin, norepinephrine. Those infusions are important because this is the point of instability. The patient's heart may start to give out at this point. So having calcium and albumin gives you an opportunity to gain some atrial fitness.
Both wires are in.
Once both wires are in, heparin is the next important drug to be administered. And that's typically 2 to 5,000 units a month of straight course. This is done in coordination with the anesthesiologist. And that's the cannula package coming through. That's the 25 French multi-stage and will go into the groin. Dr. Sappington, as a cannulating surgeon, now really has to concentrate on the cannulation and cannot really concentrate on the bite or the hemodynamic status of the patient, because that's a distraction. And typically, when we teach this on the floor, we ask that the intensivist or the hospitalist continue to monitor the vital and let the surgeon do the cannulation, because it causes confusion and you can miss things as a surgeon. You may not realize that the patient's on asystolic. And so they are encouraged to continue to manage the patient in that perspective. And also the anesthesiologist in the OR will be allowed to continue to monitor the patient.
25.
Once the heparin is given, the cannulas can now be placed in position using a dilational technique.
we have? Let's come play.
At any given time, you require chest compression. Until this patient is on the floor, there is a really wide window for instability.
Get wire? Wire moving?
Echo cannulations can be complicated by injury to vessel. You get a retroperitoneal bleed, you can get a bleed in the neck, you can have the force cannula into the chest and pull into the full space and have a massive hemorrhage. There are many things that can go wrong. It's even more fraught with difficulties in the context of ongoing chest compression. But luckily, we have had 200 cases and we have very good results.
Christian, you hand me the first dollar.
So once the femoral venous cannula is in position and clamped, the neck cannula will go, and this is a 20 French fence-like cannula that will go into the neck. And once that is in place, then Lauren here will have tubing up to the OR field, and the cannulas will be connected to the tubing, and the patient will be started. Cannulation requires help because there are long guide wires dangling all over the place that can fall into non-sterile positions. And so it is always useful to have an extra pair of hands. That's a 20 fence-like cannula that now is being attached to the guide wire that will go into position in the right into the medulla vein. Once that is in position, we'll begin.
Wait.
The position of that cannula, the large cannula, goes right to the jugular vein. It leaves the vein and goes into the chest. Then you necessarily empty the patient's blood volume into their chest within 4 minutes. And that will, of course, cause them to arrest. And it is an important complication to recognize because at that point, the chest must be open. And so they're not out of the woods until the patient is safe in the neck. And there is a chance that they still need to open the chest via sonometry if the cannula is not positioned.
The ones to come up.
Lauren now hands the lines up to Tanisha. Tanisha connects them. One line has to go to the vein in the groin, the other goes to the neck. And you have to go on the switch and confirm it with the perfusionist because they're draining from one and returning to the other. And one wouldn't want to mistake one for the other. So the drainage cannula, typically drainage.
This is my arterial. This is your arterial. Can I have saline election at place?
Always worth checking because you'd rather check twice. Get right, not check it.
Don't let that go. Mrs. Venus?
Yes.
Having someone hold on to these cannulas is important because they're not sewn in yet, and they can easily become dislodged. If they do, really, it's difficult to salvage.
We're good, connected, you guys ready?
We're ready.
Back there?
Going on ECMO.
Yeah, we're gonna unclamp, not unclamp yet, you unclamp down here for me. Okay. Unclamping arterial.
They're coming up.
1 second. Okay, open, ready to go on.
Keep going on. Coming up on flow.
The Lord stops the pump slowly. It goes by revolutions and meters per minute. And we are starting on 0 and coming up slowly. Typically, we go up to 4.5 meters per minute. And usually, the key is dramatic. Once the patient is on it, now you can oxygenate them. The complications that were affecting this young man and the compromise he was feeling from a lung perspective resolves pretty quickly from a physiological standpoint. Saturations within about 5 minutes will go back to 100%. We'll be able to have oxygen flowing in the and be comfortable with a functional heart. This is GDF. This heart wasn't working. Sometimes the heart stops when you stop redoing it. You then have to convert to DAF. This being arterial ECMO, as Jamie spoke about earlier. But in the context of a working heart, functional heart, this should do the trick.
Ron, I'm going to stay here till you guys finish what you need to do, and then we'll transport to the CVICU.
Thanks, Dr. Sappington. Did everything go okay?
Everything went great.
That's great. We appreciate all you
Oxygenation,
do.
saturations are up to the 90s. Hemodynamics are improved. Heart rate's coming down.
That's wonderful. Thank you. We will make sure to speak to this young man's family.
Absolutely,
Parents.
sir.
Does anyone have any questions in that regard? Anything for Tamisa?
Does everything need to be flushed with heparin saline? Do you flush like your cannula itself or not?
So we don't always have saline available. So I just flush everything with saline most of the time. But you should if you have the chance, you have to flush everything if possible. And with the draping, I'm sure at the beginning you guys were like, the draping, we just cut the drapes. If it's an emergency, you don't have time to, re-drape, put some chloroprep in there. Like everything's going to move really fast. If you have time, then try to re-drape. But if you can't, everything is really fast. Try to change your lugs, all of that stuff. Anything else?
Also, is it just the surgeon who scrubs in, or usually is there anybody else that scrubs in with
So the PA could come with him if he requests them. He can contact them and call them. So the PA might come, a fellow might come. It all depends on the surgeon and who they want to have come help them. If Dr. Sappington's in-house, she always jumps into the cannulations. She's one of the intensivists that can cannulate. So if Dr. Hanga calls her, she might also be there to assist as well.
So we encourage anyone who's interested to scrub in. If you're interested and you want to help, we encourage it, because right now we've become a high volume center. One of our COVID-19 results have been the best in the world. So we're communicating with a lot of institutions, and we're doing a lot of teaching. I mean, Jamie and the team here are constantly coaching. So we think that it's important that our own institution has that benefit. So anyone who's interested in ECMO or cannulation should participate. And it's our responsibility to make you comfortable with it, to make it something that brings your own capacity level up, something that you're exposed to and that you're comfortable with. So if you're ever in another institution, you can speak to ECMO with comfort.
As the bedside nurse, I've scrubbed and got stay at home helped Dr. Hanga cannulate before.
I mean, to me, that look really, really easy because I went on ECMO before, and it's chaos, and I feel like
No, it's
not knowing what to do with that tubing and everything as a scrub tech, if you've never done that, you don't know what you're doing with that.
No, and that's why we're very big on asking questions. The specialist and the perfusionist staff is trained to educate you all as well, to help you. Hey, can you cut here, clamp here, help us fill here? Do you have a bulb syringe? This is the venous cannula, this is arterial cannula. That's why we're really big on stating communication and asking questions, because we're all here to help each other, right? We want to get this patient on successfully. We want it to go as smooth as possible, and we want to all be in the know as far as what's going on at each given moment of time. So don't be afraid, honestly, to ask anything. Nothing is ever a dumb question. Even if you look at the lines now, even though it's connected to arterial, there's a blue piece of tape on it. So even just verifying that it truly is the arterial line and going to the right port is very important. Just as Dr. Sappington did back to Lauren. So just covering everything is very important. So no, you're right. She makes it look beautiful, doesn't she? Because I'm telling you right now, that crazy room is going crazy.
And that the crazy room, and as we transition to, cannulating, not in the OR, but in the ICU, it's become a teaching situation from, since the start of the pandemic. We're always teaching. There's always a lot of folks in the room because, just like Dr. Hanga said, our program is growing exponentially. So we're always looking to teach, let people take a look from outside the room, but there's always teaching involved.
Any other questions? So real quick, just to introduce everybody, on the far right, your left, is Miss Amber Gano. She's our ECMO supervisor. In the hat with the floral print, that's Lauren Herman. She's one of our staff perfusionists here, so you would see her on call. We have Lacey. She's one of the day shift supervisors in the CVICU. Christy Dixon is one of our ECLS specialists. So if you do page, one of the specialists will come with the ECMO circuit along with the perfusionist like Lauren. Dr. Sappington is one of our intensivists here in the CVICU. She's also one of the prime educators for ECMO. She helps out a lot. Tamisa, obviously surgical tech. Chris Lindsay, he's the manager of the CVICU. Trey is one of our awesome nurses in the CVICU. You all know me. And then we have obviously the one and only, the man, the myth, the legend, Dr. Heidi, the medical director.
Steps: promoting patient safety, improving health.